is Tiffany Chua, and I am currently an interventional endoscopist on faculty at the University of Florida in Kingsville. I am honored to be invited to speak by the Association of Women Endoscopists and course directors this year. Today I will discuss in brief a pathway to learning ESD in the United States. I have no conflicts of interest or disclosures. In today's talk, we will briefly review the history of ESD, compare and contrast training pathways in the East and West, and discuss current learning opportunities and resources domestically. Endoscopic submucosal dissection was developed in the 1990s in Japan as the therapy for early gastric cancer, gradually spreading to other parts of Asia where gastric cancer screening programs are in place. This technique can enable curative resection of lesions without the size limitations imposed by snares and can provide accurate histopathological assessment. ESD is currently the gold standard for treatment of early GI malignancy worldwide and has inspired the development of multiple other third space techniques, including peroral endoscopic myotomy, POEM, and a whole alphabet of POEMs, and tunneling procedures for resection of subepithelial tumors, sometimes called POET or STIR. ESD in the East typically follows the master-apprentice model where trainees are introduced in a stepwise fashion to the procedure, starting with observation, while gaining proficiency in routine endoscopy in a parallel manner. Due to the need for gastric cancer screening and also squamous cell carcinoma of the head and neck and esophagus, there is an early introduction to magnifying endoscopy, chromoendoscopy, and detailed optical assessment of lesions. As a result, Asian trainees may start learning the cognitive portions of ESD much earlier than their Western counterparts. Animal models may or may not be part of training, but ex vivo porcine specimens are somewhat easier to obtain. Patient cases usually start with small gastric lesions before moving on to other locations, versus the starting point of the rectum and esophagus that is more typical outside of Asia. EMR is also not a prominently featured technique, and ESD may actually be performed on comparatively smaller lesions. In contrast, in the West, there is a heavy focus on independent study to gain proficiency in the cognitive portions of ESD. Animal models and simulators play a large role due to lower case volume. Other important portions of the learning process include courses and visiting high-volume centers. With the gradual spread of ESD and accumulation of experience in the West, there have been also more opportunities for mentorship with domestic experts. What are some of the factors that contribute to these differences in training pathways? As always, reimbursements in each individual country's medical system plays a role. Another factor is patient needs. As mentioned before, there is a well-established gastric cancer and squamous cell cancer screening protocol in the East, whereas we may focus more on colorectal cancer, Barrett's esophagus, and esophageal adenocarcinoma and EMR domestically. Attitudes towards endoscopic training and opportunities for future development post-graduation may differ as well. Training in ESD and third space endoscopy in the U.S. is often the purview of interventional endoscopists. In contrast, endoscopic training duration and goals are often individually tailored in the East. For example, a trainee endoscopist in China with interest in third space endoscopy may seek out a position in which he or she closely works with an expert mentor in this field, without the requirement to learn other advanced procedures such as ERCP or EUS. Finally, it is not uncommon for young faculty and even tertiary care Asian centers to have their institution sponsor additional training or visiting positions at other hospitals. They may be sent to a domestic expert center or even outside of the country for durations exceeding 6 months. Unfortunately, this may not be a feasible financial or time commitment in the U.S. Next, I want to talk about some of the critical steps in learning ESD in the West. Self-study is an integral component of learning any endoscopic technique, particularly in ESD, where mentors may not easily or immediately be accessible in the U.S. The first ESD-focused English language textbook was published in 2015 and a valuable resource. Fortunately, with the increased interest in third space endoscopy, there are also an increasing number of educational resources available online. The latest innovations in ESD are well-attended events at national and international meetings, such as DDW and ESG. The ASG has also organized a special interest group in third space endoscopy with routine online and remote events, as well as in-person networking events at DDW. Endoscopic simulators have been shown to accelerate the learning curve in ESD. Animal models are probably the most common type of simulation, with most being porcine models due to the anatomic similarity with human stomachs. Ex vivo porcine specimens are now available through several commercial vendors. In vivo pig models are in theory of greater benefit, but may not accurately simulate a patient case due to the relative lack of fibrosis and bleeding. In addition, cost of preparing a live pig lab can be prohibitive. A plant-based model is an attractive option. More recently, an artificial model here made from konjac, pictured, has become available, but has not really gained widespread acceptance as it does not provide a realistic experience. Short hands-on training courses are also a valuable portion of the learning process in ESD, as well as many other endoscopic techniques. Multiple ESD-focused short courses are available in the U.S., including a combined course with the ASG, JGES, and our own Florida Third Space Endoscopy course. More in-depth courses with a lower trainer-trainee ratio are available through industry resources. For those still in training, there are also new fellowships. Third Space Endoscopy is a part of our integrated 18-month Advanced Endoscopy Fellowship at University of Florida. Mayo, Arizona also recently started their one-year Interventional Luminal Fellowship, which is separate from its Pancreatic Biliary Advanced Endoscopy Fellowship. Procedure observation is another time-honored tradition in learning endoscopy across the board. There are increasing numbers of high-volume centers and domestic ESD experts, so observation does not necessarily mean a trip to Japan. Asian centers are in general much higher volume, so it can still be challenging to observe the same number of cases in a short 1-2-week visit at a U.S. site. However, visiting an Asian high-volume center may not be feasible due to financial burden and time. Hands-on opportunities usually require a minimum of 6-month stay in a sponsoring institution to support your application for a temporary medical license. Not to mention the costs incurred with applying for a specific visa, as well as certified translation of your credentials. Fortunately, live courses and webinars look like they are here to stay even post-COVID and can provide a valuable learning opportunity. Many international centers also broadcast their courses in English, making it more easily accessible to us. What role does technology play in ESD training? A 2016 randomized comparative study showed improvement in the learning curve of trainees using a self-learning software compared to observing a conventional procedure video. More recently, a Hong Kong-based group at Prince of Wales developed an integrated AI with their Olympus-based endoscopy system, which was able to accurately identify the phases of ESD, including the dissection plane. This system was validated in ex vivo and in vivo models with hope that this AI will be able to guide endoscopists in real time in the near future. AI-based technology is rapidly developing in other parts of GI, and this may be a promising aid in ESD training in the future. POEM is an innovative technique introduced in 2007 for non-surgical management of achalasia and has rapidly spread internationally. Currently, it is no longer a novel therapy, but a well-established treatment for all types of achalasia. As another third space procedure, it does have some basic similarities to ESD, but is conceptually and technically more easily assimilated into practice. The submucosal tunnel stabilizes scope position in a procedure with predetermined steps and anatomical landmarks. Thus, people have suggested that gaining proficiency in POEM first can help build the foundation necessary for ESD. As mentioned earlier, the practice of screening colonoscopy for colon cancer and widespread use of EMR has undeniably impacted the practice of third space endoscopy here in the US. Some will say that EMR is a completely different procedure. I personally don't necessarily think so, and that there are not as many drawbacks to being proficient in EMR as imagined. Many of you who are new to ESD may already be EMR masters. While there are some obvious technical differences, some of the basics remain the same, especially optical assessment of GI neoplasia. In addition, hybrid ESD has also been proposed as an accessible way to introduce the technique to your practice. This involves creating a circumferential incision around the area of interest and dissecting the submucosa partially. The resection is then completed with a snare. Even though hybrid ESD is another possible stepping stone to conventional ESD, to be clear, it is still a valuable skill in third space endoscopy, particularly in cases of severe fibrosis, a challenging position, or when you just need a safe backup plan for the patient. Some little tips and tricks along your learning pathway. Make the most out of every routine endoscopy. Train your eye and hands in examination of what's normal versus abnormal. And you can start this even if you're a trainee beginning in general GI fellowship. Take advantage of industry training resources and courses. Really work with your endoscopy team and learn together, because at the end of the day, they're going to be the ones that support you. Decide on your procedural boundaries based on the individual lesion and patient factors before starting the case. Finally, consider taking a step-up approach to ESD by obtaining competency in another offshoot procedure first, such as POEM or hybrid ESD. Some takeaway points. Look at expertise in EMR as an advantage and utilize those foundational skills of lesion evaluation and selection to start your journey in ESD. I highly recommend looking into ESD training courses sponsored by GI societies and/or industry. This can not only give you valuable hands-on experience, but also facilitate networking and mentorship opportunities. Ex vivo and in vivo animal models remain a critical portion of ESD in the US and can help flatten the learning curve. Consider visiting a high-volume center if you can manage it. Visiting another center, international or domestic, is enriching both from the skills and the medical cultural standpoint. Start human ESD in lesions with accepted indications and less technically challenging locations, such as the rectum and thicker areas like the distal esophagus. Finally, continue to seek out learning opportunities and talk with your ESD colleagues at all stages of the training curve. Reflection and continued evolution is the key to finding your own path in ESD. These are my references. I would like to acknowledge all the people who have accompanied me and continue to support me on my third space journey. Special thanks to Dr. Sonia Riker and Dr. Victor Eislein and my Harbor UCLA endoscopy family who have made it possible for me to be here with you today. Thank you for your kind attention.